shouldn't lose the essence of the good communication skills, conveying of compassion, empathy, as well as the fact that you are there for the patient and the family throughout this difficult thing, because everything is happening so quickly in COVID that it's difficult for patients and family to comprehend. But we shouldn't we should be the connecting link for patients and family, and at the same time uh, keep the communication going with patients with open-ended questions, warmth, and empathy. This is what Dr. Param has been, telling us, and it's very, very important that we don't lose focus even through the PPE and even through the difficult situation that we ourselves are going through.
Thank you so much, Raju. Any other of the faculty members, if they want to say something? Smriti, Moira, Rajri, anybody who's this thing before I go ahead.
Thank you, Param.
Yeah.
I think it's very useful. I think I would encourage people to take that algorithm and to work it through. And you might even want to, if you have time, work it through, because we want to leave the participants able to use the algorithm at the end of the session. So there are a number of steps there, and you can just go step by step through that algorithm and help you to feel more confident about how to approach communication skills, as well as use some of the other tools that are in the document. Thank you.
Yeah, I think that's a very good idea. Thank you, Moira. And I think we may have time at the end, and while we're discussing, I might pull that out and we can have a discussion on that. Thank you. So coming to some do's and don'ts even with our faces covered with PPE and all, you can easily make out what is the mood. The patient or the attendant can make out if you're irritated, you're frustrated. So through our eyes and through our voice, we can actually, show how we feel, how we are. That is very important. If we try to make an eye contact, even if it is difficult through the glasses, try as much as possible. And every time we're not in PP, when we're discussing with the attendant, sometimes we would be like normal, maybe just wearing a mask like this girl in the picture, and you can see that she's possibly smiling behind the mask, so people can see in your voice if you are smiling or happy. So that is something very, very useful we can do. The other is that very common in our scenario that we keep calling people by the diagnosis, that COVID patient in there, that pneumonia person there in front of the patient, and that is not a very desirable thing to do. We all do that sometimes and unknowingly, but it's a good idea to at least call people by their name if you know them, and not just objectify by a diagnosis and categorize them. And same way, like a VIP, as a doctor, we need to be equal to our patients, and not that this is a VIP and the other patient feel that next bed is that it is I'm a commoner, only the VIP will get treatment. So these are some things we can do. We speak over patients like we are standing a doctor and a nurse on the opposite side, and we keep discussing the prognosis of COVID or something, and the patient is sometimes understanding. And we try to speak in English sometimes that the patient is colloquial, but a lot of people do understand English, and it is good to involve them in the discussion. I just keep telling them sometimes that this is not all about you. We are having an academic discussion with the team, and every disease being mentioned here or prognosis is not about you, or we have a discussion somewhere else.
Also, Dr. Param, I don't know about friends who have joined us from Ghana, etc. There's been a lot of cases where there has been stigmatization against patients who are COVID positive. They've been told to not come back to their houses, or their doctors who have been treated badly in this country. So it becomes all the more important for us to realize that it is not a nice thing to stigmatize, attach stigma with this. It has been seen in the past few months in India.
Yeah. Very important. Yeah, I mean, it's a stigma of a different kind. It's a stigma because of fear. That stigma, fear of infection. Yeah, absolutely right. So we need to be careful and respect the people for what they are. Another thing we sometimes may inadvertently do is that we minimize or compare patients' problems, just to make them be good. Don't get so worried over small problem. You'll be fine. You don't have complications. or there are so many people who are facing much bigger problems. People are dying. Why are you crying? I mean, sometimes we just say, usually said in good faith to back up the person, but can have negative effects. It's usually good to identify with their emotions, emotional experience, and say, reaffirm or normalize, as we say, that anybody in your position would perhaps feel the same way, or considering what you're going through, it's normal to feel this way. That will actually decrease the anxiety. The opposite may actually not. Uh, and then it's good not to forget the human touch that sometimes we forget. That may not be that possible these days too often, but if you have a full PPE, you could have a gentle touch to the patient. It actually helps a human touch while touching them on a shoulder or arm. Obviously, the cultural context has to be kept in mind. There may be societies where opposite sex touch may not be taken very well. So just keep that in mind before we do. But it is, if possible, it is always good to have a gentle touch. It reassures or makes a connect with the patient. The other is to do regular briefings. So that is very important. They are all like in this picture, you can see it's a governor of an American state who used to come every day and give briefing to patients and or the public, and this decreases their fears and removes, as somebody mentioned, false information being circulating. So coming from directly from the team leader or the head administrator, doctor, nurse who's in charge, it is very important to give. It is also important then not to give false hopes, but we should know our statistics, and through statistics, if we can tell generally that this is the percentage of people who will get sick, it might be helpful that way.
Also, in one of our earlier sessions like this, it was a very interesting discussion where we said that maybe in the COVID times, we as doctors working in the ward or working in the hospital in the ICU, can actually designate one junior in the team member to fix up a particular time to call the family members and update them on the various patients or their level, because anxiety levels are high amongst patients and families. The communication is low because we are not allowed to keep family members in proximity with the patients. So it was a very interesting discussion that led to the fact that maybe you can assign somebody in your team on a daily basis at a fixed time to start calling up bed number so and so, this name is now like this. Call the family members and update them so that they also feel that they're a part of treating their patients, because they're so far away. And you know how in India patients and families feel very strongly about being next to each other when the particular patient is unwell. So you could devise certain ways in which you could communicate what is happening to the patient with the family, like how Dr. Param showed this picture of a daily briefing. So maybe in your ward, you can designate somebody like this in your team. It's just a suggestion, but it was a very interesting discussion. So I thought I'll pull it up. It did happen last week. I thought I should share it with all of you. We could inculcate this in our practice.
Absolutely, absolutely. And this is happening. It's happening in India also, many states. I think Kerala, Chief Minister, and many other states, and even our Prime Minister sometimes comes and briefs. So that is a good thing to brief people, especially when we're in the hospital. And as you said, juniors, one point came to my mind. What we try to follow is that when there is a good news to be given, we usually plan to send the juniors. And if it is a serious communication, usually we take the more experienced people along with the juniors so that they learn how to give serious. So that is something people can follow in their teams also. All right. So from here we move on to another situation. So Ramesh's oxygen has started dropping, but we know in the ICU that he's stable off the ventilator. And then the patient comes in after Ramesh, who is very critically sick and put on ventilator, the only available at that time. And the son is obviously around somehow, through somebody comes to know what has happened, and the ventilator, which was possibly may have been used for Ramesh, has been given to somebody. He becomes very angry that my father has not been given priority. What if he needs ventilator urgently? Do you want to kill my father? And he wants to talk to somebody. It could be you. So how will you manage this situation? So what are the steps which can be taken? I mean, I would encourage if you write down in the chat box what all can be done in this situation.
Non-verbal communication goes a long way, says Shobha. Nivedya says, asked him to sit by the side.
Absolutely, these things will need to be come into, because this is a very emotional situation, and once emotional control is lost, it's I read somewhere, smart people become stupid. So when you lose the emotional control, we just don't think about anything. Anger is possibly a very difficult mood to control, and eventually it becomes rage. So rage is a situation, is beyond reason and revolves around revenge.
Some more responses. Take him aside, give him one-on-one attention, sit at the same eye level, acknowledge his anger and label his emotion. Can I please request everybody to mute their mics? We should be calm to handle his anger, says Dr.
Should
Uma
be.
Shankari.
Yeah.
Sonali says once he knows he's been given the importance and his emotions are valid and you acknowledge it, he will express more. Smriti is also adding, saying take a moment to calibrate one's own agitation state before engaging, because you yourself could be very agitated. So awareness of self is also important.
Yeah.
Dr.
It's not a good
Sarika,
idea to two people lose their mind simultaneously.
yeah, Dr. Sarika is saying tell the son about the situation and the critical situation of the other patient. So basically explain the situation. And Sonali also says, as he expresses himself, you as a provider keep taking deep breaths and offer him water.
Yeah, these are all I'm said very useful comments, because in a confrontation situation we have to understand you don't have to be right or wrong. There could be more than one rights available. What's the time? 3:40. I usually have, it's a very interesting small story I read, that they point looking at the point of view of the other person. So there was this two friends who never fought, and they were very famous in their village that they never fight. They lived in the opposite houses and they were so much love and all. And there was a bet. This and one couple kind of a bet that we will make them fight. So they made one lady, like here in this picture you can see she wore clothes which were red on one side and green on one side, and went out ringing a bell among the street, and both of them saw it. The red was the right side person saw red, the left person saw green, and then she went away. And they said, look at what was she was doing, the lady in green. She said, no, it was in red. So say, no, it was in green. I know, I'm not stupid. I saw with my own eyes. And everybody was observing, and that is what led to the fight, because they could only see one side of the lady and they could not look at the other side. And both of them were right. So the problem we make is sometimes we don't look at the opposite point of view. There can be more than one rights. The patient could be right in that, and we could also be right. So that's
Param,
called
there's a question here.
Yeah.
Also, sorry to interrupt you.
That's okay.
Suppose we tell the patients and relatives that they can ask for an SOS medication, for example, and they ask for it and it takes a long time to get the medicine administered. We did demonstrate empathy, but did not follow it up effectively. So this is particular situation. So how does one deal with it? And also there is somebody who shared an article on empathy and compassion, which is there on the group chat. So we will look it up. Thank you, Shobha, for that.
Thank you.
This situation which you have, there's a delay from your side.
Yeah, I get it. We can talk ideal, but may not follow up with action, just of no use. And we explain and properly and give something which has to be immediately used, and the patient has to go looking for it, the attendant. I think that's what he meant, the person who asked the question. Is not a good idea. So action has to be followed, so that if it's an urgent medication, we make sure that it's available and can be replaced, rather than sending the patient. So just lip service, I totally agree with the person who asked the question, is not enough. The system has to be in place and it has to be followed with the action also. So a lot of these points you already said in the chat, and that's very nice. So I'll just go over them. So we facilitating the anger to flow away, which means we listen and do not react. And we even if there is a derogatory comment by an angry patient or attendant, sometimes if we don't react, the situation won't go worse. And if the person is standing, we also stand up and listen respectfully and with a little bent, which shows a non-aggressive posturing, and try to make a pleasant eye contact. I've added 2 points to that. We experience that sometimes you need to maintain distance also. So, I mean, everybody may not get control. So it's a good idea to have a table in between or something, so that you're one arm away. Suddenly somebody doesn't lunge at you and hit you. And if you think the situation is really bad, it's good to have a security of the hospital on the standby. So once the anger is flown away, we sit down and resolve and discuss, and then we come to correct the correctables as some. So the 6 C's of communication, conflict resolution here is 4 we've already talked in the communication part, the clear, complete, concise, and candid. The 2 more required are calm. Somebody already mentioned that. I think Smriti said that, or somebody, that you need to remain calm under all circumstances. And the last is commonality. So we come to commonality. Yes, your father, we know. It's no good telling lie there. People will perceive. So your father is sick, but he does not require a ventilator right now. Yes, he might require in the future. Yes, that there was only one ventilator and that patient required, we had to give, but it is not the last ventilator. If need be, we understand. We can't cater to everybody in this situation, and I hope you also understand that how the situation is. But your father is right now stable, and if need be, we may have more ventilators in the next ward. So that way it's a commonality that you agree that you had to give that ventilator which you were keeping for him, but it is not the end of the world. So mostly people would understand. Anything else before I go to serious illness, the last segment
no,
of
I
that?
just said that they have shared an article which is there on the chat, so we will look it up. Other than
Okay.
that, but any of you feel that personal experience of how it has been when you all have worked in the COVID wards? Now, have you all had any interesting which you would like to share or chat, put on the comment?
Please
Because
do.
this is something that you all will be having on a day-to-day experience. Even the fact of wearing the PPE or in the OPD, the mask, the feel. How has practice changed? And how do you feel that the communication, which is an important aspect of healthcare, has become even more challenging? So as you listen to this, you can please put on your feeling, put on how difficult it is or how it has changed. It's a good learning lesson for us also.
All right. So we come to the last segment of this is communicating serious illness. Well, this is going to be a very important part in this COVID, where although low, there is a significant morbidity and mortality and serious illness in this, and even otherwise. So over time, Ramesh's pneumonia has worsened, and now he's on a ventilator, but he's developed something, evidence of a cytokine storm, and there is secondary infection, and D-dimer levels are high, and organ failure sets in, and the prognosis becomes really, really grave. So how to communicate these issues? You can still keep writing if you have any thoughts on it as I go along, and what are the important parts of a serious illness or adverse prognosis, or what we say called breaking bad news communication. So, Rajam, if there's anything, we'll discuss.
I
Yeah.
will let you know. As of now,
So as we see that this poor person is saying that I know bad news, but you don't have to whack me with it. That means make it a little gentle to the people. And how do we make it gentle? Till we are thinking of any responses, I just thought to add this in between is initially before 1970s, people thought it is inhumane to disclose bad news to the patient, or try to put up a bright things, and things have changed. There are changing paradigms. Palliative care is very importantly coming. So there is not the end of the world. If there is no cure available, there is potential for care instead of cure. And there are new symptomatic treatments, as you've been discussing and will be discussing, end of life and, morphine and everything. And there is more individualism, and people want to know. And so this is more and more our responsibilities to tell a correct information and prognosis to the patients or their families as the patient requires. because it has been found in research that doctors who are find it difficult to give bad news unduly prolong harsh treatment sometimes, and that doesn't work well for the patient or the hospital either way. And now in India also, as a legal charter, I can't open this file, but there is available on the human resource and ministry this thing that you are required to give all the correct facts. So if there is no comments, I'll go through the protocol which is we follow while giving adverse news. It's called SPIKES protocol, which stands, as you see, SPIKES. So it is steps what we follow. S, or the SPIKES, stands for setting up the timing. So it is something like I talked about a normal interview, this thing that it should be uninterrupted, distracted. Usually people use some separate rooms for a patient meeting when you have to talk about the adverse prognosis. There is no phones, everything is quiet, possibly place to sit, and there is correct positioning where you are looking and with near the person you're talking to also, if you need to hold or touch the person or offer some water. So that is a good setup. And then you ask for P is for patient perception. What do they think? Sometimes you may be wanting to give a almost fatal prognosis, and they would be thinking coming, yes, we heard that our father is better, and and they expect that everything is fine. So you may have to tailor how you tell depending upon the need for that. So perceive what the patient already knows or the attendant knows. E is for invitation. You ask them that we need to disclose something. Is this the best time? How much you want to know, how much your family wants to know, you want your family to know. These are all things called the invitation to tell, before tell. And then it is knowledge, as I said in the previous, clear, non-technical, slow. That is where we give the knowledge, and then deal with the emotion. There can be emotional overload and people need support that time. So empathy is very important. And the last is, once things are done, we make a strategy and plan for the future. Now, it's very important here is that we don't have to do it everything right away. We can do it in steps. We can have more than one meeting. And if the patient is too overwhelmed or the attendant, you can say, this is the information, you give a handout or something. We can have a COVID handout or something. Go read this, and then we can come back and see what you want to do and what you want to plan. So this is the SPIKES protocol. This slide is about reaction once it's an overwhelming reaction to grief, and it's where are we? 351. Okay, so these are different steps. This is a very overall reaction to grief by Elizabeth Kubler-Ross, very famous model that once you come to know, there is initially a denial, anger, then bargaining, followed by depression, and the last is acceptance. It's been very beautifully modified here. I'm not sure if this is in the ebook, but by Dr. Jitin in the COVID context. So by denial, we meant that, oh, this is just a flu, like many people said, can't happen to me. I am young. I don't have comorbidities. Nothing will happen. Then once things start getting worse, we are angry. This country did it. This country started. The government didn't react. Our hospital didn't react in time. Then the next stage, all stages usually don't have to be followed actually. You could skip stages so people react differently. Then there is bargaining, especially in our setup, like where we say, oh, this is a punishment for some old illnesses, old sins we committed, and this is how we bargain. Our sins have been washed away. Then comes depression after nothing is happening, that, oh, I think a lot of people are going to die in this thing. I mean, people near to me may also die. And this is same for us. This could happen to us. This is happening to normal people during this time.
So,
and the last
Param,
is,
sorry, you finish it then.
No, just the last is acceptance. That is the time when you say, oh, this is what it is, and now we need to stand up and act on it. Yeah.
So very important question by Shilpa, which we would have touched anyways, that in COVID-19 patients are deteriorating rapidly. So, you might not have time to go through. So how to go about it then?
Go through what? Sorry, Raju.
In COVID-19, this Elizabeth Kubler-Ross grief model takes a little while. The patients and family might not have the time or the space to actually go through all this, because things are rapidly changing in the patient's clinical condition.
Yeah. Absolutely. No, that's what I'm saying. This is not something we tell or we follow or a protocol or an algorithm. This is just a observation by Dr. Ross, and which is that this is usually how people behave when they have a sad news. In fast, absolutely right, Rajam. They may just go from denial to depression to anger to acceptance, and so these are bypassed. Even normally in COVID times, I agree with the person who said that everybody may not go through all these stages.
Just another point which I would like to make here is that's why the importance of palliative care during COVID times becomes even more heightened, because bereavement and end of life is, which we are going to talk about the next couple of days, is very, very crucial, because family has just not got the time to accept what's happened to their loved ones. And hence it is very, very important to focus and train and in the palliative care aspects of COVID management, because a lot of things are very different from that of a chronic illness.
Yeah, absolutely. And in lot of things are different. I mean, in COVID, it's absolutely even clinical deterioration so fast. Forget about normal this thing in ICU. People are talking one day and then the oxygen is low. Somehow they cope up very well with low oxygen before they go to a critical level and they are in ARDS.
Yeah.
So yeah, and I mean, our communication skills really come into importance right now to how to deal, and we may have to improvise. This is just a guideline. We can't do everything or every time. This is just a baseline on which all of us need to build upon in the context of the situation.
Yeah, and like Smriti points out, it's not necessary that everybody goes one after the other. People often oscillate between these states, and Moira very clearly points out that is the reason it's important to discuss goals of care early on and not leave it when the situation is in absolute emergency and panic. So the whole concept and ethos of palliative care, goals of care for the loved one, to discuss it early on so that we are not faced with an emergency.
I totally agree with that. And something what Moira said, we follow in other diseases also. Let's say, for example, cancer. So, you say how to tell the bad news and how to do, we don't, in that case, we have time. So when we have time, what I usually like to follow in our neurological illnesses, that not once you have the bad report in hand, that is not the time you ask for all this spikes model. So what we need to like to improvise is that when you take a biopsy or do a electromyography or in a motor neuron disease suspected, that is the time we start the communication about when to, how much to tell, who to tell. That time neither I know nor the patient knows, so we are very honest to each other, and that information is very valuable that time, so that when actually the bad results come, how do we go about it, who to talk to, the son, the patient himself. So that comes in handy in my experience.
Only thing is the difference in COVID patients, like all of you have pointed out, the clinical scenario changes so rapidly.
Yeah.
That's why Moira has also suggested that we know now that elderly, those with comorbidities, don't do that well with COVID. Therefore, on picking up these subsets of people, we can start discussing goals of care using these communication skills of Spike's protocol, so that when the moment comes, we are all prepared, that we know what the patient and the family wants. So it is very important, therefore, to start using these pearls of communication skills in order to identify those high-risk patients and have goals of care for those patients. So very, very important.
Absolutely.
Otherwise, of course, the surrogate decision or what is the
Yeah.
pressing point at that particular point in that ICU, that will end up making the decisions. But there is a lady here called Shilpa Khanna. I think we should, at the end of it, come back to address her question, maybe ask her to ask the question towards the end. So
Sure.
Shilpa, if you can be
We'll
patient with us, we'll finish and come back to you.
Yeah, it's the last slide anyway.
Yeah.
This thing. So I'm just saying that one more thing we need to very honest with the patients is we don't know everything about this disease. This is still evolving. There are reports coming in every day. A friend in Singapore was telling me that they are seeing asymptomatic patients sometimes later come back with vascular complications. Young people who are not comorbidities, or children are presenting as immune disorders like Kawasaki disease. So we don't know, we cannot give hope to anybody, assurance to anybody. So this we need to know, because it's a new disease. We need to tell the patients that actually we don't know everything about it. And the last is the self-care. To end this with that, we need to take care of ourselves also, so that we can communicate properly. We need to have a routine, good exercise, whenever free, meditate, indulge in hobbies, because it is very stressful time. And if we don't take care of ourselves, and like we keep using in these talks, that if we don't have they say, have your own seat belts, oxygen masks on in a airplane emergency before you can help people. So it's very important to have our own oxygen flowing. Otherwise, we won't be able to help the people next to us. Uh, this is where I end. And these are resource materials. Some of them are already mailed to you. But if anybody needs more, you can always get back to us and obviously give our feedback. And this is all the people who have contributed to making these slides, in addition to Dr. Biju. And some of the slides I've used is from the resources of the American Society of Communication in Healthcare, with whom I work. And so thank you to acknowledge all there. And thank you very much.
So thank you, Param. But just wanted to ask Shilpa Khanna if you can want to ask your question, so that our other extended faculty, the more senior ones like Moira, Smriti, and even Dr. Rajeshri can answer. You were asking something about clinical deterioration. Do you want to go ahead and ask? It'll be, please unmute yourself and go ahead and ask. And Param, if you can, yeah, excellent. Shilpa, do you want to ask your question?
Hello.
Yeah,
Am
Shilpa.
I audible?
Yes, very much. Please go
I
ahead.
just wanted to ask, when Sir Dr. Param said that we might not have to go through the whole routine of in a single meeting with the patient and their family. So my question was, what if till the next meeting the patient deteriorates very rapidly, and earlier he was going on rapid organ failure, and now the decision has to be made whether to put him on a ventilator or not. So I was just, feeling that it's very cruel to expect family and patient to come to terms with such rapid clinical deterioration, and then having to make a decision which they are not ready to make.
Absolutely. Param, would you like to take it, or is open for Moira?
I can say what I feel, and then I'll leave it to the other experts. Just one thing, what I was saying, as I said in the beginning, the session is not only about COVID. This is more in the chronic diseases, where we tell people to come back. But in urgent situations, it is not necessary to ask them for a second meeting always, if it's not clinically feasible. We sometimes just take a small break, lay a 5 minutes break, go have a cup of tea, go with your family member, sit outside. They don't feel intimidated to take a call exactly that moment when in front of the doctor, healthcare workers. So we just walk out of the room and then tell them to think of, maybe want to have a glass of water, cup of tea, we can reconvene. So the timing will depend upon obviously the urgency. If it's very urgent, we can't leave it to another day. Anyone else want to?
So basically, Shilpa, what I wanted to say is that yes, COVID does deteriorate rapidly. And that is what is important to say, that now we know that elderly people with comorbidities do deteriorate. So it will be a good idea in the beginning itself to have the discussion. All God willing, if it all works well, then, it's not that your discussion has gone in vain. But if it doesn't go well, at least you have done the discussion at the right time, following the right protocol, in an empathetic manner, so the family is prepared for the worst and hoping for the best. This is exactly what you want. And especially in a COVID situation, all your medical ethics come into play. You do what is in the best interest of that patient, cause him no harm, and at the same time, a patient who can be saved and salvaged is who probably requires that ventilator, especially in low income countries where there's always a constant struggle. So I appreciate that fact. And somebody else, Shobha, I think, has said that yes, even 90-year-olds have come out of it. It's true, but the majority of cases, it has not been the case. That is the reason to have these communication skills in your armamentarium, so that you use it effectively, timely, and have unhurried conversations when you have the right opportunity. But that's what is the biggest challenge that COVID has thrown for us, that things can change rapidly, as well as that you don't have the time because of the volume of patients, plus the PPE, which becomes a huge physical barrier for your communication. So given all these limitations, we need to use our skills most effectively is something that we need to, especially in this situation, because things can change rapidly. Moira, you would like to add something?
Mike, we can't hear you. Unmute.
Sorry, I think it's a great discussion, and you took us back to some of the algorithms we looked at in day one. So please review those and come up with excellent questions. What I would say is, even in an emergency setting, don't forget the stage where you elicit the concerns of the patient and the family. You know, sometimes we move straight into information giving. So even if you don't have time to go through those steps, the reason Param was teaching you is not so that every time you go through steps. It's so that you learn a skill and then you apply that skill in the setting. And if it's a quick setting, you do the quick checks, but you don't forget them as easily if you've learned the step-by-step steps. Yeah, does that make sense? So elicit concerns. Make sure you're aware of what people are concerned for and their wishes. Don't go straight into information giving and make those decisions together. And I agree, age alone is not a factor. It's age plus comorbidities, very importantly, pre-morbid status. And a paper just out today is supporting the functionality as one of the indicators, how fit somebody is, how much they're able to look after themselves. It's a very interesting time, isn't it, that we discover all these issues about this new disease, but Dr. Param has very nicely reminded us this is relevant for all chronic disease settings.
That's why I would just like to highlight on two things. That one, we need to make this a part of our daily medical practice. So it will come use as a second skin even when you're treating COVID patients. It's very, very important to make this a protocol that you need to sit the patient, eye contact, verbal. These are small things that you need to inculcate, mainly because from where we come as a part of training, it is not an important part of our training. So just focusing that communication is extremely important in daily practice and is heightened in COVID situation. So we just need to follow the algorithm, learn this and practice, practice, practice. I think it makes a huge difference in the way you communicate. It is not something that you're born with. It's an acquired skill, and all of us can become great communicators in the languages we are comfortable in.
Absolutely. I have, as Moira suggested, I've opened the algorithm with me. If anyone has it open and want to discuss any point in that, then I'll share it in the meantime. I just wanted to say that, you know, we are talking about all little bit in a good, but we need to know the back of our mind that things can worsen, and we've seen it happening it in India and abroad in many cities. So very, very unique challenges can come up, especially in the communication part and distress, which is going to be taken up on Friday, where your duties as healthcare workers may be in conflict with the situation. It is not only that whether to put somebody on a ventilator or not, which we normally talk about in situations like in sick patients with bad prognosis. There may not be enough ventilators or machines sometimes for people who actually need them. So this is something which happens only in a pandemic crisis of this kind of a sort. Doesn't happen normally. Normally it's only about the medical part of it and the person's values. Here actually some needy people may be deprived of the things which are available, the facilities. So at this time we need to keep our heads on our shoulders. Is very, very important. I hope it doesn't happen, but if any one of us works in that situation, it can get quite distressing.
Param, can I have one clarification? In your anger management slide, you have shown some alternative reality. Could you explain on that? And one more is on pearls.
Okay. Alternate reality was related to that story which I was telling, that they can be, both people can be right. Sometimes the conflict comes out that we only stick to our point of view. And I mean, alternate reality is that accepting that there can be more than one right possibilities in a conflict situation. Like in Ramesh's case, I was saying that we are right. We had to give the patient a ventilator required. Ramesh is stable. Where coming from the son's point of view, my father was there before, he might need it in the next hour, and he's coming, that anger is coming from that point of view, that thinking from one side. So he's not thinking about the other patient who needed.
Exactly.
And we are thinking. So that is what I meant by alternate reality, is that there can be more than one point of view which could be correct in a given confrontational situation.
Very clear. And one more about pearls. That pearls, something like perception something?
Yeah, did I put the slide up?
Yeah. Partnership, something?
I think it was just part of another slide. I don't think that those tools are in the ebook. So
Yeah.
the spikes tool is the one that is there in the ebook. And then tomorrow, sorry, on Thursday, the distress session, we will be looking more at how to manage empathy and how to frame empathetic statements.
Yeah.
So the Pearl tool is
Pearls,
a bit
yeah,
like the nurses tool.
Yeah,
Let's
Pearls
maybe
is
stick
like
to
the
one.
nurses tool. Different acronyms are used for almost coming to the different goals, core set of values. But yes, Pearls is one of the ones which we use.
That is partnership, emotion, appreciation, and the next three I am missing.
Perhaps what we can do, Dr. Raji, is stick to the ones in the ebook for our sessions here, and then we can share that on our faculty pool.
Fine,
Yeah.
thank you.
So I hope, are there any more questions? We are happy to take one more. We have about 6 minutes left. Anybody else who wants to share an experience or some difficult communication or a difficult, we're happy to hear you out, or any suggestion or question. We have time for one more. Please feel free to ask. And thank you so much for an engaging discussion, because you, by having such an audience, we learn and we know, what you are all going through from different parts of the country and the world. So it's nice. Please please put down if you'll have any questions that you'll need to be answered. And as you leave today, can I please request you all to just put in something that you all, one thing that you have learned today, or that has changed the way you think about medicine and medical practice, especially with this communication, that if something that you would like to put it in the chat box, it will be a great feedback for us also. And anyway, you have the feedback form, but one thing that you have learned today that will stay with you and carry with you. So thank you all, and see you all tomorrow at the same time for End of Life. And the facilitator is going to be Dr. Rajeshri, co-facilitated by Dr. Roop. Smriti, you will see her usual beautiful face at 3. So lovely to see all of you. And I really like this participation and engaged discussion. Please keep this, and also read your ebooks for tomorrow, and we will all see you soon. Lovely to have you all this afternoon. Thank you very much. Have a good day the rest of the day. Bye. And please don't forget to fill the feedback, which will pop up in your screen thanks to the ECHO team. Please fill in your feedback, read your ebook, and please feel free to get in touch with us. Thank you.
Someone's mentioned in the chat, is it a Dr. Shobha, red pill moment? Yeah, maybe once we come into dire situations, sometimes unpleasant truths have to be said and decisions have to be made. And so we may have some red pill moments in COVID care.
Dr. Anant Krishnan has said very honestly that he has been 2 don'ts that has been mentioned. I do even daily. Now I'll try and learn to do the do's. Extremely encouraging. Anant, we've all gone through this and probably still make mistakes, and we need to learn from these mistakes.
Absolutely. I mean, it's very candid and honest of you to say that we all do that. Even teaching, the day you take a talk and go back to your outpatient, sometimes you can lose your cool. We all take time to, we can't be perfect in a day.
And there's no right or wrong. You have to do what you're comfortable with in the setting that you are in the cultural context that you're working. You need to figure out a way that you communicate well with your people. The bottom line being compassion, empathy, giving them the listening ear, and be there for your patient and family. Otherwise, you do it your way, I'm sure it works well.